So the second debate is on replacement versus repair for secondary MR. So Paul's going to start with replacement as the preferred strategy for secondary MR.
All right. So I hope this is easier. So this is my title of the assigned title, Secondary MR Needs Replacement. My disclosures. So when we look at mitral regurgitation, we know that there's primary and there's secondary MR. We know that when there's primary MR, the focus really is on trying to get them to surgery and preferably mitral valve repair. Whereas for secondary MR, it's more about guideline-directed medical therapy and possibly surgery, either repair or replacement. And it's a very difficult question to answer, but I think the focus of this debate very appropriately will be on the CTSN data. And the data are pretty clear. This trial randomized 251 patients. They had to have a severe ischemic MR. They were randomized to either downsized ring or mitral valve replacement that was chordal sparing, and the primary endpoint was left ventricular and systolic volume index. And when you look at these data, initially when they had the first one-year follow-up, there was some concern about the early hazard of operative mortality for patients who had replacement, but by 2 years, there was no difference in the survival between patients who had repair versus replacement. And the study wasn't really powered per se for mortality. And again, that was not the primary endpoint, but again, these are observations that are important when we're looking at the data. And the crux of this trial is that when you look at the rates of recurrent MR, for patients who had repair, it was 59% at 2 years versus 3.8% for patients who had replacement. And I think that's where a lot of the focus is on deciding whether a patient should get repair or replacement if the mortality is considered to be equivalent. An interesting observation is that despite these differences in recurrent MR, there were no differences in the primary endpoint of left ventricular volumes. A little bit difficult to explain, and if you look at the way the results are described, there are some subtle differences in patients who had successful repair versus not and such, but it is what it is in terms of left ventricular stroke volume. But I think overall, despite the lack of difference in the primary endpoint, there are some trends that were trending in the wrong direction. If you look at repair versus placement, in terms of what we consider to be a failed index surgery, it was higher for repair. If you look at the rates of heart failure and follow-up, it was higher for repair. If you look at the rates of cardiovascular readmission, it was also higher for repair. And so, again, the study isn't really powered for that. It's a small study, just 250 patients, but these are some concerns, and I think it's led a lot of people to think about simply replacing these patients and not repairing. And I think the difficult thing here is that when you look at MR, it's completely different from aortic stenosis. MR leads to volume hypertrophy, and then that volume hypertrophy begets more MR. And whenever we're doing surgical correction of MR for these patients who have secondary causes, we know we can take care of one arm, but we're not quite sure if we can take care of the other arm. And in the end, there's still a lot of concern of whether MR reduction, whether it's incomplete or complete, is actually curative or even helpful in these patients. It remains a significant source of debate. But let me just show you a couple other things. So in the TVT data for mitral clip, there are some interesting observations. If you look at FMR versus DMR, the secondary MR patients with incomplete MR reduction with mitral clip, half of them were dead or had heart failure hospitalization by a year. And so I would propose that we're not helping these patients a whole lot by incompletely treating their MR. We know that we help them some, but the COAP trial will help us later on tell us exactly how much we're helping these patients. Another important observation in CTSN that I think we should all be aware of is that the baseline ERO was an average of 0.4. So people have argued, and I think very appropriately so, that these patients were very severe in terms of the ischemic MR. The guidelines have defined severe secondary MR as either 0.2 or 0.4, but to have these patients all average 0.4, it tells you that the pathophysiology is quite advanced, and there are people like Pat McCarthy who said, I would have never enrolled or randomized patient in that study because I would have simply replaced them because it was all pathology that was already off and gone. But in the end, when I look at a patient, these are the things that I think about when I think about repairing or replacing. And I'm not a surgeon, but obviously we have these conversations with our surgeons. I think it comes down to two things. I think it comes down to the risk of recurrent MR and the risk of complications related to the prosthesis. And I think about certain things like the valve anatomy. I think about the need potentially for reoperation in the future. Could a patient stand another operation? And in terms of the prosthesis complications, I think, well, how long are they going to live? What's the likelihood of that prosthesis eventually degenerating? And then just in that last comment about anticoagulation, we tend to anticoagulate our patients who have mitral prostheses, or would they be able to tolerate Coumadin if, for some reason, we were to find thrombus on their valve lifelong? And so these are some of the things we think about, and predictions are always challenging about the future, but I lean on my echo colleagues. You look at it in terms of tenting area, the coaptation distance, how big the LV is, things like sphericity index, whether it's a basal aneurysm, all these factors will likely predict recurrent MR, and I encourage our surgeons to really think about replacing those types of patients. If you look at the STS registry, the STS registry, and look at repair versus replacement, there are differences. Different patient populations could get treated with either, but in general, if you have a higher likelihood of an STS problem, you're more likely to get replaced. And I think that reflects a lot of our approaches in the fact that, well, if we get one shot, we're going to just replace the valve because we don't want to have to think about reoperating on a high-risk patient. So that's another important consideration. And then this other thing I also think about is, well, what is the natural history of these patients? How long are they going to live? We know that if they're just treated with medical therapy, that the 5-year survival is well under 50% for patients who have MR. But if you look at the patients who have surgery, this is a meta-analysis, 36 studies that looked at repair versus replacement. The 5-year survival, not a whole lot better, 66%. So exactly how long would they live with that prosthesis? If they're very young, it's one thing, but if they're in their 70s and 80s, you know, there's a good chance they won't make it another 10 to 15 years. They may not need another valve surgery. And then the final thing is, again, just in the last question from the last session, in terms of anticoagulation, you know, these valves can thrombose. You know, this is a news headline many of you are aware. It's about the Fortis valve, which has been shelved now, but I think we all have anecdotes and experiences with thrombosis on mitral valve prostheses, particularly if it's transcatheter. And then the final thing I would say is, will TMVR change our choice of repair versus replacement? And I think it potentially could if the operative mortality is low. Now remember, there were some concerns in the CTSN data that suggested that there's a higher operative mortality for replacement versus repair. But when you look at these data that are out there, these valves are being put in the sickest of patients, and they're being put in safely. And so I think if operative mortality is not an issue, but recurrent MR becomes the issue, and the patient can tolerate prosthesis, I think the balance will shift more towards TMVR, or at least mitral valve replacement. And these are data that I've already shown you, and this is our first patient who was treated 2.5 years with Tendyne. This is him at the gala. Here's another patient. They gave me permission to show them. They're doing fantastic. And I would, our program has leaned more towards TMVR. We haven't enrolled a patient in COAP in 3 years now, and the reason for that is because our patients just do tend to do better with TMVR. So in summary, I think the repair versus replacement choice, it needs individualization. There are a number of things to consider, but I think most data tend to suggest that replacement patients do better, especially if you're looking at recurrent MR in a severely ischemic MR patient. I think in the future it's going to come down to a choice between residual MR versus the prosthesis and which one you're going to be willing to tolerate. And then finally, I would say that TMVR, if the risk is low and the prosthesis is durable, it could become a preferred choice. Thank you very much.